All righty. Aloha, everyone. Welcome. Yeah.
Hi, Mark.
Thanks for the wave, Mary. Yeah. So thank you all for making the first quarter regional all-member meeting that we have set up for today. So we have a packed agenda. So why don't we get started here? Please mute your microphones during our presentation. Any questions you have, please enter them in the chat box, and please feel free to share any experiences that we have when dealing with partnerships and community health and our coalition work with our group today. For housekeeping purposes, please enter the following information into the chat: your name, organization, your coalition name and location, and any activities or updates you'd like to share with us. So our pulse check for today is: how can Mountain Pacific Quality Health support you? And we want to make sure that you folks update your member names and contact information. We collect all this information and then use it to send out information to you through our listservs and through our constant contact. Are there additional or potential partners for recruitment that you want to report, or can we help at all in recruitment of any other people for our coalitions that we have? For the metrics and data, we have our analytics team with us today. They're going to help us out. But if you folks have identified any of the important areas of focus in your community that you would like to look at, please let us know. Make sure everyone has a coalition participation agreement for new members. And this all-member meeting is today. The next one will be on April 25th. It is, yeah. Our goals for the work that we do is around the work that's done in adverse drug events and to reduce deaths around opioids and opioid best practices and reducing deaths. We have chronic disease management that goes from hypertension to cardiac rehab, decreasing A1C and slowing the progression of CKD. Care coordination across the different settings. Hold on there. Emergency preparedness plans and immunizations. And these are the areas that we're targeted to work on after our contract mod popped out. For our first polling question today, I know we have been reaching out to many of you and you probably already answered, but for those of you who haven't, do you have an emergency management plan? And we're looking for a yes or no answer. That looks pretty good, 93%. For those of you who have answered no, if you would like some help, please put that in chat. We have a couple of new templates we've been working on that if you don't have a plan that would provide you with a plan that you could fill out, do a checklist, get it back to us. CMS requires 100% of all of our partners that we work with have a plan. And I know there are some community-based organizations. So if you are out there and you have a plan dealing with tsunamis, hurricanes, any kind of plan for evacuation or a disaster, then that would plan to be part of what we were doing also. So, okay. You want to end the poll then, Mary? So next slide. We're going to have some general updates today on the coalition itself. As far as analytics are concerned, we have a couple of team members with us, Ray and Liam, and we're really excited about that. Before we get to that, we're just going to talk about a couple of general updates that deal with culturally and linguistically appropriate services. They're called class standards. And what I'm sure many of you are already using, race, ethnicity, and language data. Oh, let's take a look at this. So national class standards are a blueprint for advancing and sustaining class policy and practice. The blueprint provides an in-depth explanation of and how to implement strategies for each of the national class standards. There is no single correct way to implement the national class standards. Your organization may decide to implement some, but not all, or your organization may wish to implement some sooner than others. After deciding which standards to implement, you can refer to the blueprint for ideas, and you'll see a link here, and we'll have a couple of other links later on in the slide deck that we will have for you as resources and tools. The principal standard calls an organization to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health benefits. And these come into practices, preferred languages, health literacy, and other communication needs. The national class standards can be applied to a wide array of professions and sectors, including medical care or behavioral health, public health, social work, community health, emergency health, and more. The HHS Office of Minority Health developed the standards to advance health equity, improve quality of services, and help eliminate disparities. The standards were first published in 2000 and updated in 2013. For race, ethnicity, and language, we're looking at real data. We will know how and who is suffering the most from poor health outcomes, and we'll be able to provide targeted interventions to improve the health and well-being of beneficiaries. The purpose of real data collection is to identify macro-level trends in health disparities by race, ethnicity, and language, and individuals' healthcare data will remain private, protected, and confidential. We have another polling question for you. Which of the following class resources does your organization currently deploy? And please select all that relate to your organization there. A, use real data to identify needs, describe current care, and improve care. B, collect real data from all individuals receiving the services you offer. Have created and implemented a formal class plan within your organization. Deliver or make available continuous class-related trainings. And have completed an organizational assessment specific to language assistance services.
Mark, and I'm unable to launch it. Do you see it on your screen?
I don't see it on my screen, yeah. Okay, well, how about if we come back to that later?
Okay.
All right. We are really honored to have Dr. Zia Khan with us today.
Hi, can you hear me?
Yeah. Dr. Khan is the clinical cardiovascular chief at Queen's Heart Institute here in Hawaii, president of the American Heart Association board. And today, Doctor is going to talk to us about highlights from the ACC-AHA guidelines for hypertension. I'm going to stop sharing right now, Doctor, so you can share your screen, okay?
Sure. And you can hear me fine, Mark? Can you hear me okay?
I hear you very well, Doctor. Can everybody else hear too? Okay.
Yes.
Good.
There we go.
Yeah, thank you so much for inviting me. Let me just get my screen situation sorted out. So I'm gonna go.
There we go.
You can see it well. Let's see. You see the presentation or you see the
You see the notes.
notes? Okay.
If you do the drop down for display settings at the top, you could switch that.
I may just. I'll just do it from. I'll just share this other screen. I'll just do it like. Sorry, I'm a WebEx person. Okay. I'm just gonna go from here. So I'll do it like this. It's okay, I guess.
Yeah.
So yeah, thank you for inviting me. I'm basically going to go over the American Academy of Cardiology, American Heart Association hypertension guidelines. As I was introduced, I work at Queens and volunteer with the American Heart Association as the current for the state as the current president. And so I don't like to hear myself talk too much, so I apologize to myself and to you, but hopefully you'll get something out of it. And it's basically going to review the guidelines. It's relatively controversial. Apparently, recently the American Academy of Family Practice came out with some different guidelines. We can go over that. This is going to be relatively a basic talk about some issues in it. If you have any questions, just put in the chat box or just feel free to speak up, and you can stop me anytime. I'll try to be relevant. And if I'm off topic, you can, or if you want me to concentrate on something else, just let me know. And so for background reading, these are the 3 guidelines, and then now the AFP have their guidelines out as of December. But in the past, these were sort of the main guidelines I looked at with the ACC and then the European Society of Cardiology afterwards, and the International Society of Hypertension. So they're good documents and just understanding the approach to high blood pressure. And just for background, some epidemiological considerations. Obviously, as you guys know, it's a priority for you. Hypertension and chronic diseases has a very high prevalence, and the prevalence increases as you get older. And depending on what you use for the cutoff, the prevalence changes. So if you use a cutoff of 140 over 90, and this is based on the NHA-NES study from 2011, 2014, that population, the overall rate was about 30%. But if you look at the ACC, which uses a cutoff of 130 over 80, it's 46%. And then as you get older, it increases. So 75 and above, it increases almost in women 85%. So it's a highly prevalent disease. And the lifetime of risk of hypertension is high. In the MESA study of patients who are people who are 45 years of age without the diagnosis of hypertension, the 40-year risk of developing hypertension was 93% for African Americans, 92% for Hispanics, 86% for whites, and 84% for Chinese ethnicity adults. In Framingham, patients who are free of hypertension, 90% of adults free of hypertension at age 55 develop hypertension during their lifetime. So as you get older, it's very common, as you know. And then just the associated morbidity generally, in 2010, high blood pressure was the leading cause of death and disability adjusted life years worldwide. In the United States, hypertension accounted for more cardiovascular deaths than any other modifiable risk factor, and was second only to cigarettes in terms of all-cause mortality for preventable deaths. And then the associated comorbidities are important. In adults with hypertension between the years 2009, 2012, 15% were current smokers, 49% were obese, 63% had bad cholesterol, 27% were diabetic, and 15% had chronic kidney disease. And so, and then on the bottom is just sort of how the ACC defines relatively fixed risk factors and modifiable risk factors. And so the modifiable risk factors are like current smoking, diabetes, dyslipidemia, obesity, physical activity, inactivity, unhealthy diet. And why that's important is because there's sort of a model of behavioral change where if you hit one thing, other things follow. So for instance, if you stop smoking, you might find that you exercise more. You might find that you eat healthier. And so attacking one of these things can really help, and your medication adherence may improve. So attacking any one of these things can have a sort of a domino effect. So it's important to see how this is associated with the other diseases. So that's more so generally the comorbidities. And if you look at vascular disease, this is a meta-analysis from 2002 of 1 million adults with no previous vascular disease. And it's a sort of a log linear scale of risk on the y-axis. and blood pressure on the x-axis. And if you note in the bottom, each line is a decade, 40 to 49 years old, 50 to 59 years old, 60 and 69 years old, and so on and so forth. And so if you look at the bottom three, if you move from 120 to 140, it's almost like double the risk of stroke, ischemic heart disease, and other vascular causes. Now, so that's pretty significant. As you get older, that curve sort of flattens a little bit. And so that the relative risk is less, but the absolute numbers are significant because there's a higher rate of high blood pressure in that population. So you're dealing with more people, even at 80 and 89 years old. So that's important to note. How we define hypertension matters. So if you look at the American Academy of Family Practice recently, they would define it differently than American Academy of Cardiology. And so American Academy of Cardiology defines it normal being less than 120 over 80. Stage 1 is 130 to 139 and diastolic 80 to 89. That's significant because it was a change from the 140 over 90 previously. The American Academy of Family Practice would say that's too aggressive, and they go for 140 over 90. And with people with heart issues, 135 over, I think 135, I think was over 80. And so that the reason is because of, I think the idea was that cardiologists were too myopic and were focused on heart attacks, but to the risk of syncope and hypotension. And so that was the concern, that there was an incremental benefit and a decrease of MI, but there's increased risk of syncope and hypotension. So just something to keep in mind, particularly as patients get older, what you're kind of shooting for. But I think 130s is reasonable. And no, 135 was not that far from 130. So I feel like my patients are uncontrolled. It's usually not that kind of gray area. It's usually like way higher. So I feel comfortable with that change. How you take blood pressure matters. So if I don't know how many of you work in a clinic, but I know in my clinic, it's not what this says. So this is from the International Society of Hypertension. Basically, it's to be in a quiet room, comfortable temperature, no smoking, coffee, exercise for 30 minutes. You have to have an empty bladder, relax for 3 to 5 minutes, take 3 measurements at 1 minute intervals, use the average of the last 2 measurements, no talking. I had a patient who was a physician the other day, and he was talking to me the whole time while I was remeasuring his blood pressure because it was too high. And so the bottom line for me, and before I go there, I'll just show you, this is from the ACC guidelines on how to properly measure in clinic. And it's very similar to what I just said. And so the bottom line for me is I really don't put a lot of stock in office blood pressures because I don't know what the percentage of patients doing this, but I would say it would be less than 1 in my clinic. And it's a busy clinic, 15-minute visits established. And so to do all this is difficult. So just take those numbers with a grain of salt, I would say. So my personal practice is I put a lot of stock into out of office blood pressure measurements, and particularly home blood pressure monitoring. Ambulatory blood pressure monitoring is great. It has shows that there's better cardiovascular outcomes than office blood pressure monitoring. Home blood pressure monitoring may trend that way. I think the data is not significant, but it's much more practical. And so just before I talk about home blood pressure monitoring, what is ambulatory blood pressure monitoring? Basically, you wear a monitor and it remotes in every 15 minutes during the day, 15 to 60 minutes at night, and it can provide an estimate of the mean blood pressure over the entire period, or you can separate the day and night. You can see who's a nocturnal dipper and who does the opposite. And it'll tell you like when there's periods of hypotension, and then maybe you give a short acting and hypertension. A lot of people have that cortisol surge and high blood pressure in the morning. And so it helps if you can figure out that pattern and you can treat appropriately. Also, yeah, so that's the utility of it. And it's also reimbursed. I've had a hard time finding it, and we don't have it. I think Lanai Community Health Center, Joe Humphreys, I think he has it. It's one person I know, but in the state, I don't see that too often. The more practical alternative is home blood pressure monitoring. And basically, the basic way to do home blood pressure monitoring is sort of outlined here. First, making sure that they're trained on how to take your blood pressure at home. Using specified devices, the ACC document has a list of specified devices, and then instructions on how to do it properly, like we outlined before, remaining still, don't smoke, all that stuff, sitting 2 feet on the ground, and taking the multiple readings. And so there's a nice handout from the AHA website, which I would recommend. So I give this to my patients because it's colorful and it says all those things in a very simplistic way with a diagram. And so I give this out, and then I say, this is sort of the path, this is sort of what you should do. Yeah, and then how does that correlate between the clinic and the home-based blood pressure monitoring and the ambulatory blood pressure monitoring? So I look at the 130s, and so that's sort of where I want to go. As you get higher than 130, the correlation kind of changes. The clinic blood pressure tends to be higher than the home-based and the ambulatory blood pressure monitoring. So something to keep in mind, but for me, practically not so important because I'm trying to shoot for 130 for most of my coronary artery disease patients. Yeah, and if I miss something in the chat, feel free to just let me know, look at the chat box. So part of the home-based blood pressure monitoring and the office-based blood pressure monitoring is a significant percentage of my patients either we're not waiting long enough to take the blood pressures or they have white coat hypertension. And so how that plays out is if you look at home-based versus or office versus out of office. So either they're both normal and you're good, or they're both high and they have hypertension, or they have no hypertension in clinic and they have hypertension in their home-based out of office, then they have what's called masked hypertension. And if they have high blood pressure in the clinic and they have low blood pressure in the community, then that's white coat hypertension. So I want to talk briefly about white coat versus masked hypertension. White coat hypertension, looking at the data, so it's generally 20 over 10 millimeters of mercury higher, and it's increasing age, female gender. Those are sort of the more, and if the clinician watches you while you're taking the blood pressure, it tends to be higher versus if you are unattended. And so oftentimes in clinic, I'll just turn the lights off, I'll leave the door crack and I'll leave and I'll repeat the blood pressure measurement. That being said, there's a higher, the risk is you're going to be more likely to develop hypertension in the future, but you're at minimal increased risk of cardiovascular complications. In fact, you're more likely to be overtreated and have syncope and hypertension. So it's important to do the ambulatory blood pressure monitoring before you give a diagnosis, or a home-based blood pressure monitoring. So I personally, I know you're supposed to get 2 different measurements in office at 2 different times, but I really like the home blood pressure monitoring in between to really solidify the diagnosis. Masked hypertension. So when would you consider to screen at home? So if you look at the EKG, for some reason you have an EKG and it shows left ventricular hypertrophy. If you have or left atrial enlargement, or you have an echo and it shows left atrial enlargement, or it shows left ventricular hypertrophy, or any sequela that you think, I don't look at the eyes routinely, but if you look at, or if you have chronic kidney disease, or you have target end organ damage in your eyes, or you have end organ damage with a normal blood pressure, that should raise your suspicion for masked hypertension. And then you look at the home-based blood pressure monitoring. I guess some patients are very calm to be at the doctor. I'm not sure the mechanism, but in either case, that's a reason to screen. Evidence of target organ damage without elevated blood pressures in clinic is a reason to screen for masked hypertension. So what are some basic causes? I'm going to just some basic causes. I think basically people look at the genetics of it first and say, oh, I think a lot of patients and people in general point a lot to genetics. And I think if you look at sort of most of our chronic diseases, there's a huge environmental component. And so environmental risk factors are probably the major cause. And then there's also secondary forms of hypertension. So if you look at genetic predisposition, hypertension is considered a complex polygenic disorder, and there's many different loci that influence blood pressure. Now there's some blood pressure disorders that are clearly correlated with genetics, and those are listed there. But in general, by the time when these guidelines were written, they thought that about only 3.5% of blood pressure variability was due to genetic predisposition. So the majority of it comes from environmental factors. So what are the major environmental factors? So overweight, obesity, given our population, given the processed foods, given the lack of activity, that's probably one of the biggest drivers of high blood pressure. And there's a direct relationship between BMI and blood pressure that's continuous, and there's no significant threshold with that. And it's even stronger if you look at central adiposity and waist to hip ratios. The high blood pressure is even more strongly linked to that. If you lose weight, you lower your risk of hypertension, your blood pressure improves. Physical fitness, Modest levels of physical activity are associated with decreased incidence of hypertension, so that's important. Another risk factor is alcohol. So some would argue that about 10% of the population blood pressure is elevated by alcohol. Now we know that alcohol helps with certain degree with cholesterol panels and cardiovascular risk. It also increases your blood pressure, so that's something to note. So in general, moderate intake at best is recommended. So other environmental risk factors, sodium intake is well established for stroke, for cardiovascular disease, other adverse outcomes. Salt sensitivity, that's often considered a group characteristic. We don't test for that, but those with CKD, diabetes, metabolic syndrome are considered, salt sensitive. Potassium intake, so fruits are important in terms of lowering blood pressure, and it's inversely related to blood pressure. So potassium can be encouraged to help lower, I would say nutritional potassium as opposed to potassium supplementation would be important to encourage through fruits. So those are some of the major environmental factors. Obviously, smoking, I didn't put that on there, but those were some of the bigger ones that I thought were important to nail. Non-pharmacological approaches to treating hypertension. So the patient's blood pressure is like elevated, 128, 130, low 130s. They don't have heart disease. How do you approach this? I like this table from the guidelines. This one's really, I think, important to me. And so if you're just taking a second and looking at this, so the reason this is important because it sort of it quantifies to a degree for the patient how much you could lose. So if you lose a kilogram of body weight, expect a 1 millimeter mercury reduction in your blood pressure. And so a healthy diet, what does that mean for the DASH diet, dietary approach to stop hypertension? A diet rich in fruits, vegetables, whole grains, reduce sodium intake. Optimal goal is 1,500 milligrams per day. And then again, next to it shows you how much you can probably on average decrease your blood pressure. And then how much potassium do you aim for? So this is a pretty good, I'm going to go to the next slide. So physical activity, hitting 150 minutes a week, and how much can you see your blood pressure drop? And then sort of different types of exercise, and then alcohol consumption, limiting it to 2 drinks a day. For those who drink more, what can you expect? So I think this table is pretty important for those patients who are interested. And just reading this can help just quantify, and so it brings the message home. When do you look for other causes of hypertension? So most people have primary hypertension. When do you look for other causes? So most common causes, you want to look for sleep apnea in people with high blood pressure. Just that could be screening questions in a sleep study if needed. Drug-induced, alcohol-induced, kidney disease, primary aldosteronism is probably one of the more common causes that are not primary. Pheochromocytoma, these are relatively rare. Cushing syndrome, thyroid disorders, aortic coarctation, hyperparathyroidism, adrenal hyperplasia, and so on and so forth. And so how do you figure out if it's primary versus secondary? Primary gradually increases as you get older. Secondary hypertension is often episodic and labile, or it just suddenly goes up, and maybe it's because they started a medication. If they're dizzy, palpitations, or younger, consider pheochromocytoma. Primary hypertension is linked heavily to lifestyle risk factors. So that's something to think about. And then family history is also more common in primary hypertension. The other causes for secondary hypertension, just look for the different disorders, right? Like kidney disease. If you look for hypokalemia related to primary aldosteronism, so when you're getting a basic metabolic profile and you see a low potassium, something to consider if they have muscle cramps or muscle weakness. If they have hyperthyroid symptoms or hypothyroid symptoms, that's important. And then checking their medication list as well as the rest of the stuff on here. So, and then the basic testing you want to do, again, you want to check the lipid profile, you want to check their kidney function, their TSH, the EKG for sequelae of high blood pressure, an echo if needed. I'm going to go forward. And so basically, you really only want to screen if there's indications clinically for secondary hypertension. For the most part, if the shoe fits primary hypertension, you just go for it and treat it. And so this is another example of a nice algorithm in the guidelines that you can look at and say, who am I going to screen? And you just kind of go through it and say, okay, look at their drugs, look at the pattern, look at their age if they're less than 30 years old, look for target organ damage. outside, disproportionate to the degree of hypertension. Diastolic hypertension in older folks is indicative of sometimes a secondary cause, because as we know that the systolic tends to increase, diastolic tends to go down. If that pattern isn't like that, it's generally not the normal pattern. And then also put in the chat box if I'm over on time, I can skip slides as needed. So primary aldosteronism, this is something probably also to look at. I'll give these slides out if you guys want to look at them. But basically, when you have low potassium, you have high sodium, or you suspect it, this is something you may want to screen for because it's a little bit more common and it has significant cardiovascular implications, including increased risk of stroke, 6.5 increased risk in MI, 12 times increase in atrial fibrillation. And so these are things that you want to screen for. And the best screening, most accurate screening is aldosterone to renin ratio. And this kind of talks about how to screen for it. And then treatment. So I usually do the screening and then I send them to endocrinology for the confirmation. And then depending on what they want to do, you can do surgical or you can do this just higher doses of spironolactone. I kind of work with a patient on that one. And so that's sort of the treatment method for primary aldosteronism. Again, it's in the guidelines, you can read that. Renal artery stenosis, the main thing to take home from renal artery stenosis, if it's younger folks, as a cause of hypertension, you don't really revascularize. And so if it's plaque and it's older folks, you don't put stents in. And we learned that like 10 years ago. So that's not something you stent. You treat a person with atherosclerotic renal artery stenosis, much like you would treat someone with coronary disease with statins, aspirins, that kind of stuff, and treat their blood pressure. Really not a reason to stent. No intervention needed there. If it's fibromuscular dysplasia, they're younger, that is a reason to do a balloon angioplasty. That will be told by imaging. We'll show you what sort of pattern there is there. If they're on 3 or more medications and they have some of the risk factors, and you want to send them to a cardiologist or endocrinologist and to do the secondary workup, I think that's probably appropriate. So if you have 3 good medications on, their blood pressure is still high, that's a great reason to send them over, and then we can kind of do some of the screening. I always go back and forth when to do Dopplers, renal ultrasounds. I haven't found a lot of utility for it, particularly because I know I'm not going to be stenting, especially if they're older and the pattern fits, primary hypertension or something else. But something to note. I'm going to go forward. Obstructive sleep apnea. The thing to note about obstructive sleep apnea is the effects of treatment are relatively small. So I really don't see the case where obstructive sleep apnea is a primary driver of hypertension. I've been finding it like a comorbid condition because they have other comorbid conditions, obesity, and they have obstructive sleep apnea. So you could treat, and as you guys may know, people have a hard time with a CPAP. And so, but it could be, so the quid pro quo there is if you don't want to push the CPAP early, is push the weight loss to say you may not need as higher pressure, or you may not need CPAP if you lose weight, if they're a very obese person. So there's some, I think, trade-offs there. But eventually you do want to get treated for it, because besides high blood pressure, you can have right ventricular failure, which is problematic. And so it is important to treat CPAP eventually, sleep apnea eventually. So some drugs, basic drugs that you want to look at: alcohol, amphetamines are notorious. And so what I see, and I don't know if the clinicians out there see this, I see young kids with high blood pressure who are like struggling in school, and like university kids, and they tend to be on amphetamines. So that's, and then you kind of negotiate with them, but they don't see the long-term sequelae because of temporal discounting. They don't see the idea that you can't really see that far in the future as human beings. You kind of see what's right in front of you. And so it's really hard to convince those guys to stop their, Adderall or whatever. But that's been one situation. And so you try alternative therapies for ADHD if that's what they struggle with. And some antidepressants, some antipsychotics, caffeine, phenylephrine, Sudafed. So chlorpheniramine is a good alternative. And then certain herbal supplements, NSAIDs, and then recreational drugs, corticosteroids. So the list is right there, and you kind of look through it and see, just make sure you look for those causes. And then what do you do for medicines? There's many things you can do for medicines. This is just a general approach. So that 130 over 139, which the American Academy of Family Practice disagrees with, So if the way the ACC AHA adjudicate it is looking at the cardiovascular disease risk score for atherosclerotic disease. So basically, if your 10-year risk score is greater than 10%, and the score, if you don't use it, is on the website, it's often used for cholesterol. We use it for blood pressure. If it's greater than 10%, we treat to that goal with medicine. If it's less than 10%, we don't treat to that goal. We go to behavioral stuff. And so that's the triage point. And so for me, almost everybody has that goal because I'm a cardiologist, so everybody's already there. So I treat pretty much to 130 over 80 or less. On those original slides that with the 4 age groups that was kind of going up and the younger guys go up higher with vascular risk. If you look at where it starts, 115. And so the correlation starts at 115 is better than 120. And so we don't talk about that, right? We say, okay, that's normal, but it can go, I mean, you can have you have minimal risk, but you have some risk. And so it starts. And so for me, I'm very comfortable with saying less than 130. I do appreciate the idea of syncope and hypotension. I've had that happen multiple times, particularly, but in some cases, I've found disease. So why would somebody have, I would try to target 130, 128, and they would find that they have, stenosis, intracranial stenosis. And that was the reason why their blood pressure was going down. So I would say definitely individualize that 130 goal. Some patients, yes, some patients, no. If they're really healthy and they're 85 and they're super healthy, which we have a lot of patients like that in Hawaii, I would say maybe be more aggressive. If they have a lot of comorbidities or wheelchair bound, they have a lot of intracranial disease, maybe back off a little bit and just be happy with, perfect, this saying perfect is the enemy of good. There's a question in the chat box. How are you promoting home blood pressure monitoring with your patients? Do you loan home blood pressure machines, or must interested patients purchase their own blood pressure machines? That's a good question. I think that American Heart had a program once where they helped us get blood pressure machines. Then Queens helped us get blood pressure machines. In general, we don't have blood pressure machines now. So I just basically tell them to get it. I do whatever I do. I just listen to my patient. I try to find, I'm sure as clinicians, I'm listening. I'm not used to talking as much, to be honest. So, but I listen and I try to figure out what their hook is, right? Because part of, unfortunately or fortunately, whatever, being a physician is trying to sell people things and sell them ideas. And so I listen to what they would benefit. So if they don't want to take medications, how do I get them invested in home blood pressure monitoring? I say, you may have white coat hypertension. I don't put a lot of stock in office blood pressures. The only real way I know you're going to have high blood pressure is if you take it at home. The other issue is my patients are fairly compliant, no matter what their economic strata is for some reason. I think in Hawaii, we have I don't know, maybe because I'm a specialist. I think you have that extra gate because you're coming in as specialists, and the specialists are a little harder to find. Maybe they're more committed. I'm not sure. So we may have a bias there. But for general, I don't have a lot of compliance issues with that. But I do sometimes dangle the carrot that we may not need all these medications if your blood pressure at home is better. I'm just reading the chat. Yeah, that's interesting. I think for Hawaii, if we had better, and if everybody knows this, better access to ambulatory blood pressure monitoring, or even resource like a library. That's a great idea. A library where people could borrow blood pressure machines. That would be very interesting. So definitely interested in that. So that's how I go between the 130 and the 139 is the or the 140 is the CAD risk score. This is just the rest of it, saying if your blood pressure is 130 and you have a low risk of CAD, you just reassess in 3 to 6 months. If you have a high risk score, you try to reassess and then you may treat. That's saying just when to follow up. Like, so for someone who's a low risk score, 3 to 6 months. For someone who has a high risk score, after the diagnosis, 1 month. If they have even higher blood pressure, stage 2, follow them closer. And then people who have very high blood pressure, you want to be obviously very aggressive with choices. So what do you choose first? So first line agents. It used to, I think an article recently came out about clothalidone versus hydrochlorothiazide, and everyone was very much like chlorthalidone is way more effective. It has a lot more electrolyte issues. But now it doesn't look like recent data. I have to go back and review that hydrochlorothiazide is not that much worse. So that's good. So that diuretic is one thing, calcium channel blockers, ACE inhibitors. I would say, as you probably know, let the disease state help pick your first line drug. That's probably like if they're diabetic, maybe an ACE inhibitor, that kind of stuff. If they have medication compliance issues or they're elderly, maybe a calcium channel blocker is better. And so another thing is monotherapy versus combo therapy. My preference is, so this initiation antihypertensive drug therapy, the two first line agents of different classes, either as separate agents or a fixed dose combination, is recommended with those with stage 2. Single antihypertensive is reasonable at stage 1. And so for me, I think I agree with that, but the minimal dose, the better. So if I can get a lisinopril hydrochlorothiazide pill versus separating it out, I would do this single one because adherence is such a big issue, and giving one pill shows benefit. Combination pills show benefit. I'm going to skip forward. So this is about resistant hypertension. So if you have patients and you're not getting, this is the kind of patient a cardiologist probably wants to see. I get a lot of patients who are self-referred. They say, "Oh, I have high blood pressure. You're a cardiologist." But I think primary care probably does a better job, honestly, managing, and they have better population health systems sometimes. I think what we would definitely probably want to be a part of is if they're on 3 or more medications and kind of just managing that. That would be helpful, because that's when we start looking for other causes and trying to help. I think that's where we can add value, and that's sort of what everybody wants. So special groups, I'm only going to target one special group, and that is, the special groups are disease state groups is what they mean, like coronary artery disease, kidney disease, and how you treat those. But the only one that I really want to target on is the elderly population. And so, and this is important because this is where the controversy lies. So the AHA, ACC, and their guidelines came out saying 130 over 80, which used to be, some of you remember it was 150 over 90 at some point. So saying it's 130 80 is a pretty big change. And so talking about that is an issue. And then the family practitioners guidelines just came out, more conservative, 140 over 90. And those with heart disease, 135 over 80. But I think in my mind, how do I, put all this together? Again, physiological age is more important than chronological age. So if they're not dizzy, they're exercising quite a bit, and I want to lower their risk of stroke, because a stroke or heart attack would be really problematic, and there's no real risk of syncope and hypertension, I may shoot lower. If they have some risk of syncope and hypertension and they're frail and they fall a lot, and they're not they're deconditioned, I'm going to be much more liberal. So they kind of separate this in saying a class 1 indication versus a class 2A for people with high comorbidity and limited life expectancy, do a risk benefit approach. So I'm more consistent with these guidelines than not. The main way to sort of, and so I think most of that is what I said is pretty basic. There's a little bit of controversy in the sense of what is the actual goal. But it is pretty straightforward. But the issue is everybody is like half of our patients are uncontrolled, even though they have hypertension, even though both you and I are treating them, they're still uncontrolled. And so why are we so unsuccessful? And part of it is because we don't do population health well. We don't do sort of that teamwork that's needed. And so this section, the only thing I would like from this talk is maybe you just look at those guidelines. Because and the European guidelines are actually really good because they have better pictures. But the team-based care section is really interesting in both of them. They tend to be in the back. And so I would look at that, because I think team-based care, if it's not already accepted, we all understand that's the future of this. And so first is just looking at medication adherence and using combo pills as opposed to individual doses. That'll definitely help. Up to 25% from their data do not fill their initial prescription for antihypertensive therapy. I thought that was crazy. The average, at any given time, they only have about 50% of their medications with them. And only 1 in 5 patients achieve the adherence rate that are in clinical trials. So we have real adherence issues, even with our most adherent patients. And then looking at, so a team-based approach, look at also a holistic approach. And so there's companies that do like a lot of behavioral telehealth. There's another company we talked to another a few months ago that does calls for they'll do high blood pressure management and just do remote monitoring and that kind of stuff, and ambulatory data, remote blood pressure data, and they will call and they'll go over strategies. And touching base with the patient outside of clinic is, I think, super important. And just looking at cognitive behavioral strategies. Again, if you hit one thing, you probably hit other things. So if you focus on stop smoking, you'll probably do better in high blood pressure because you'll start walking and you'll lose weight. But again, just that's how the mind works. A lot of people, one of the thought distortions is all or none. So if I'm smoking, then I must be very unhealthy. What's the point? And so just kind of working on all those thought distortions and trying to make movement in one area may have sort of a domino effect in the other area. So just understanding the importance of cognitive behavioral stuff is really important. So medication adherence, sort of cognitive behavioral coaching, and team-based care. So team-based care includes the patient, the PCP, the other subspecialists, nephrologists, endocrinologists, cardiologists, nurses, pharmacists. So one thing I've been trying to push, but I've just been too busy with other issues, is either a pharmacy or nurse practitioner run population-based blood pressure clinic. The hard part is all the stakeholders. And I think, so for us, when we do quality programs, it's really easy to say, okay, we're going to do a coronary artery disease program on how we do chest pain from the ER to the cath lab to discharge. And then, but it's very difficult to say, we're going to do a high blood pressure program with cardiology and this diffuse primary care network. Because as you know, it's hard to get data and different things. But really, if someone could organize that, that would be very powerful. And then the in-between calls, and that's the sort of thing. I don't think you need to be a pharmacist or a nurse coordinator or anybody. You can have community. Data has shown that community navigators are very helpful in just calling and making sure patients are following appropriately. And then leveraging Epic and whatever your EMR is for that population health level data for your clinics. That's very helpful, and just seeing where you need to target things. And I'm just going to go one more. And then using telehealth or remote interventions also help improve hypertension control. So I think having multiple touch points is very helpful, and having some remote capacity is very helpful. We're not there yet. I think we're making steps towards it, but I wish we were further along. So just kind of in summary on the team-based, or how I would say one flow of looking the important things of how to look at blood pressure. This is from the guidelines as well. Make sure you do your best to measure the office blood pressure accurately. If you can't, then try to get home blood pressure monitoring. See in your head, do they have secondary hypertension? Look for any end organ damage. Start lifestyle changes. Use that risk score to help determine your target. Is it going to be 130 or 140? Align treatment options with their comorbidities. If they have angina, maybe start them on a calcium channel blocker. Look for age, race, ethnicity, sex, or differences, or anything that would tailor your treatment as well. Ensure good follow-up. Use team-based care. Use remote monitoring or telehealth to connect with the patient. Look for non-adherence. Look, and then also, it's not in here, but also just kind of refer. I would say if you have multiple medications and you're still struggling, I would refer to a specialist. Any questions? I'm going to stop sharing.
Oh, does anybody have any questions? Thank you so much, Doctor, for sharing your wisdom and experience with us today.
This is Catherine Borganick. I don't have any questions in particular, but I really appreciate your approach as being what is appropriate for the patient and what can the patient do versus these are just the guidelines, this is what you need to do, and really base it on the patients. That's so helpful.
Thank you. I appreciate that. I'm just going to put my email in because I think because of the nature of your group, if you have good ideas on sort of population approaches, I think that's where we fail as clinicians, is we're very like office based. And so if you have ideas, I just put my email in there. Feel free to send me some ideas. The question on home blood pressure. So if you look at that handout, It's on the website. Everybody's different. So morning, evening, because then you catch the sort of, it's a pattern, right? I'll let you know, there's a dip in the morning, or so you do it twice, morning and the evening. So it says in the handout, I'll say like, before medications in the morning and then before dinner in the evening. Anything else?
Oh, thank you very much, Doctor. We really appreciate your time today. Thank you.
Welcome.
Okay, can you folks see my screen?
Yes, we can.
Great, thanks, Mary. Okay, I'll stop sharing, and Ray, you can take a look at some of the analytic work. Oh, wait a minute. All right, let's stop here. Before we go to that, we do have those class resources polling question that we ask, class and real. So if all of you could choose as many as are available and being used currently by your organization. Class and real are, I realize a lot of you folks are already using real. I'm not sure how many of you have already put in class plans or implemented some of those. But this is a direction as we go forward, part of health equity, and like we said, the Office of Minority Health within Health and Human Services. All right. Thank you all. Okay, then let me move on from here. I will stop sharing. And Ray, go ahead.
All right, well, first of all, thank you everyone for having me. I'm a member of the analytics team here at Mountain Pacific. In the interest of time today, we're going to dive into some admissions and readmissions data across the Mountain Pacific region, so our 4 states of Alaska, Hawaii, Montana, Wyoming, and the Pacific Islands. What we're seeing here is admission rates amongst the fee-for-service Medicare beneficiary populations within recruited zip codes across our region. From left to right, on the very far left, we have Q1 of 2020. So of course, right before the pandemic really hit its stride. And the latest available data we have is over here on the right, and that goes through September 30th, 2022. So we can see our admission rate over that time has trended downward amongst the fee-for-service Medicare beneficiary population. And I should also mention, this is based on Part A claims from the databases maintained by CMS. But that being said, overall, we're seeing a downward trend in our admission rate per 1,000 beneficiaries. Right now, we're hovering right around 30 admissions per 1,000 beneficiaries. But really, once you get into the state level data, the story becomes a little bit more interesting. Let's look at Hawaii, for example. The admission rate right before the pandemic was right around 28 admissions per 1,000 beneficiary years. Obviously, it tanks in Q2 of 2020. And then slowly rises as we get into Q3 of 2022. As you can see, that is starting to approach pre-pandemic levels, just something to keep an eye on. But really the question is, what are the diagnoses behind these admissions? Why are people entering the hospitals? And with that, we can dive into admissions by diagnosis. So this is just raw counts of admissions as indicated by ICD-10 diagnosis codes. And just to hit the highlights here, again, we're looking at regions, so across all of our 4 states in the Pacific Islands. The most frequently occurring diagnosis codes are associated with CKD, far and away the highest. That's that purple line across the top. And as you can see, in any given quarter, we're looking at about 7,000 admissions that have CKD associated with them. It's a very prevalent problem across all of our states. In second place is diabetes. That's the yellow line you see there. Again, in any given quarter, we're hovering around 6,000 admissions associated with diabetes. And in third place, we have heart failure. Heart failure has been extremely consistent through over time, as one might expect. And also, you have to note sepsis. It's been extremely consistent. In any given quarter, we're looking at approximately 2,000 admissions associated with sepsis. Moving on, we'll take a quick look at 30-day admissions. I know we don't have a whole lot of time, so forgive my speed through all of this. If you have questions, feel free to reach out to us later. But that being said, let's look at some readmission rates. So again, we're looking at fee-for-service Medicare beneficiaries. This is our 30-day readmission rate. Again, Q1 of 2020 over here on the left, going to Q3 of 2022 on the right. As far as our overall region, we are trending downward, which is great. But again, in Hawaii, we are seeing an uptick in our readmission rate. And in fact, I think we've just ever so slightly surpassed pre-pandemic readmission rates in Hawaii. Alaska, for example, is still below pandemic levels. But overall, as a region, we are trending downward, which is great. And I think it's by and large due to a lot of our partnerships with a lot of you on this call. So thank you. It makes my job a lot easier to give good news as opposed to bad news. But that being said, we'll take a quick look at the diagnoses associated with these readmissions. It's a very, very similar story to what we saw with admissions. We see CKD is the most frequently occurring diagnosis code, or set of diagnosis codes, I should say, followed by diabetes, that yellow line, heart failure, and then of course, sepsis is down there in that orange line. If you are interested in data specific to your state or data specific to your PCH, feel free to reach out to the Mountain Pacific team. We do provide that data as best we can to everyone. I know we've provided some to some of our Hawaiian coalitions. And if there aren't any questions, I will stop presenting and hand it back over to Mark with the few minutes that we have left here.
Hi, Ray. This is Shelley Somerville with HMSA. Do you have an idea of why chronic kidney disease has been on the uptick so much?
You know, I don't have a clinical background. I'll say that from the get-go. But as you can see, the admissions and readmissions plummeted in mid-2020. And really what we saw is an uptick specifically in CKD diagnosis codes associated with those early stages. So I think some of them are attributable to people essentially avoiding the hospital, not knowing they have those early stage CKD issues. And then all of a sudden they get back in there and it's easier to detect or more apparent because it's further along. That would be my theory.
All right, thank you.
Thank you, Ray. We have a few upcoming events here to close out. It's Worth a Shot series, meeting registration that are held weekly on Wednesdays. In-person meeting in Hawaii, Advancing Healthcare Innovation on February 22nd. It's a very collaborative networking and very innovative look at healthcare here in Hawaii. And you can link to the registration here. And then we have a pain and opioid management series coming up. And the meeting registration there will be here also. Let's move on here. We wanted to ask another polling question, and this one: does your organization track readmissions, emergency department utilization by risk setting, diagnoses, or reasons? Yes or no, please. Thank you, folks. About 74% are saying yes. And then Kyla, are you on board?
Yeah, Mark, I'm here.
Okay, so would you like to take a look at these first three here for references and resources real quick for us?
Yeah, sure. And I did put in the chat too that pain and opioid management series is going to be really good. It's going to focus on non-opioid pain therapies, and it's hosted in Alaska, but open to everyone in our region. So I encourage folks to sign up for that. Part of the curriculum in that starts in February. The first session, actually the second session, I think, is actually going over the CDC practice guidelines for prescribing opioids, which is the first resource listed on this slide. And then we will be talking about, there will be folks talking about the mechanisms of pain, and then just kind of going through and talking about adverse events that we see with opioids versus using non-pharmacologic or non-opioid pain therapies. And then we've updated our website to have good resources for all of our states in accessing naloxone. And nationally, if you're having issues locating naloxone in your states, the Get Naloxone Now is a national website that you can go to see what availability is. Thanks, Mark.
Thank you very much. We appreciate it. And for those of you who'd like to look more into the culturally linguistic and appropriate services, we have a couple of other Quinn QIO sites here, one with Superior Health and the other one with Comagin. And we have one more polling question for you. Does your organization have tracking tools for ED visits? Anybody who'd like help with any of these types of tools or resources that we've talked about, please reach out to us at Mountain Pacific. We're happy to help. I'm happy to try to assist you in any way that deals with quality improvement. Okay. So we're looking at about 53% that say no and 47% that say yes. Does anybody have any questions? Thank you all for hanging in here today. If you do have any questions, please, you can send them to me at mmarabella@mpqhf.org. And our next meeting will be on April 25th. And we will be posting this on our website in about a week. You'll be able to get to look at all the different resources and all the things going on there. Anybody else have any other questions or anything to add? Kevin Frankie talking about a grant. Okay, 3-year grant, it's free to us. Sorry. My email address is mmarabella@mpqhf.org. Thank you all very much. Thanks for hanging in there today. Talk to you later.
Thanks, everyone. Bye.
Thanks, Mark. Bye-bye.
Bye-bye.